we will talk a little bit about this as we move into our first discussion point, which is symptoms, because chronic inflammation and symptoms are all related. Okay. So MPNs, again, associated with chronic inflammation. We've talked about this because of that abnormal signaling pathway. And you can see here just a slide talking about what the common symptoms that we see in ET and PV are, because that's what we're talking about this morning, and also how we evaluate these symptoms. And so you can see to the right here, the MPN SAF, which was developed by Dr. Ruben Mesa in part. And it's, again, the way that we monitor symptoms and look at these things within the context of clinic patients. All right. Categories of symptoms. I'm going to talk through this and then we'll go back and forth with some questions between us. So remember we said that MPNs are associated with chronic inflammation. This is relevant because chronic inflammation drives a lot of these symptoms. And so when I think about the different symptoms in MPNs, I think about different categories. So number one, constitutional symptoms. So again, these are the inflammatory symptoms. People get fevers and night sweats. People get weight loss, headaches, pain. These are all because of that chronic inflammation. People get microvascular symptoms. So symptoms where the little vessels get clogged up and people get associated symptoms from that. So you can see headaches, trouble concentrating, which is obviously tough for a lot of folks, peripheral neuropathy, dizziness, and then itching. You can get symptoms associated with having a large spleen. So you can imagine if the spleen is big, it takes up space and people get full faster when eating, and you can have decreased appetite. And then you can also get, as a fourth bucket, toxicities related to your therapies. So as we think about these questions, we're going to go through that. Dr. Coltoff made an excellent point here.
Yes. I think not included in those kind of 3 or 4 facets of symptoms. Is this working? Yeah. Or success. Okay, great. There's a large kind of like psychosocial burden with MPNs, right? I think we discussed in the other talk that this is a rare type of disease. There's, fundraisers, there's walkathons, there's all these things for breast cancer, lung cancer, all these other conditions. But I think having an MPN can be very isolating. I think a lot of my patients have either stopped working because of their MPN or retired early or have stopped doing things they like to do. So I think this is just a very illustrative slide done by Claire Harrison, who does all of the work in the UK, looking at kind of the mental burden of MPNs. And, I would say a majority of patients kind of reported feeling depressed, anxious, worry that their condition will get worse. And, these things kind of go hand in hand with physical symptoms sometimes, or they can be out of proportion to physical symptoms and kind of dictates how you treat.
All right, we'll get to the exciting part. So I came up with a list of questions. So these are the things that patients have asked me in clinic. And so I'm just going to ask you a question and we'll go back and forth. How's that?
That sounds great.
Okay, so we'll go back and forth. And if you guys have additional questions, just feel free to ask. So number one, okay, what are the most common symptoms you see in your clinic for patients coming in with ET or PV? What do you see most commonly?
There you go. Yeah, I think the slide that was presented a few seconds ago is probably the most accurate one. Fatigue, far and away, is probably the most common symptom that I see in people either newly diagnosed or people who have been managed for a while. Sometimes it's tough to kind of parse out, right, is this just fatigue because you have 3 small children and you're working overtime? A lot of people have fatigue in general, or is it more of an insidious fatigue that, you're doing everything you can for, you're getting sleep, you're eating well, and still just kind of limits your daily routine. So that's the most common symptom I see. And then after that, I think it really does vary depending on a lot of factors, age, type of mutational status, other comorbidities or, symptoms or medications. But I see a lot of pruritus. I'm not sure that's, itchy skin. I'm not sure if that's because we practice in the South or not.
Sure.
And then, I really do think anxiety around the diagnosis and just the psychological burden is probably one of the more common things I see as well. Yep. How about you?
I will agree with all of that. How's that? And then I'm gonna take the second question. So how do we manage some of these constitutional symptoms? So I'm going to choose fatigue because I think that's the most common thing that I typically see patients presenting with. People come in and they just cannot function. They're tired, right? How do you manage that? And I really take the approach of a team within MPNs. And so I don't think it's I'm not the best person to manage everything, right? So there's so many adjunctive things that people can do to help combat fatigue. And I think we underutilize them. So there's so many things like exercise. We talk a lot about diet. So Angela Fleischman out in California has talked a lot about whether, an anti-inflammatory diet has any impact. So there's lots of things that as a patient you can do to help with these symptoms. So again, exercise, meditation, things that help you decrease stress within the context of your life. We do a lot of adjunctives for fatigue. So sometimes we use medications, and that's helpful, especially if people have big events, things they need to get to. And then we really do take a group approach. The common question I get asked a lot is, are there supplements, anything I can take from a supplement perspective? So I love this slide. And I put this up here just to help answer this question. So this was a survey looking at patients with MPNs and looking at the various supplements you can see listed on the right that patients were taking and whether or not they impacted the score, the MPN SAF score that patients had. And you can see that of all these supplements that people were taking, and they went from, vitamin D, vitamin E, green tea, the whole 9 yards, medical mushrooms, medical marijuana, everything is on here. There's only one thing that has a positive p-value that's statistically significant. So what I take from this is that supplements may help people, individuals, but there's really no data to broadly support use of supplements. All right, next question. How do you manage vasomotor symptoms?
Great question. On top of all the symptoms, I feel like the vasomotor symptoms, and especially like itching, can be really, really bothersome for people. I mean, I think not far and away, but very commonly that's really the most annoying and just aggravating symptom for people. It depends on the scenario, right? I think for people who are on a daily aspirin or who are not a daily aspirin, I recommend at least starting a daily aspirin. Most patients with PV or ET are on aspirin already, but some low risk, quote unquote, people might not be on them. So starting aspirin is good. If someone's already on aspirin, there's some data to suggest that maybe doubling the aspirin, take it twice a day, can help with some of these vasomotor symptoms. I think this kind of gets into the next question. I think anything over twice a day is starting to get a little bit excessive, but there are some situations where it might be helpful. And then, in the context that it arises is important too. So if this is someone, let's say with PV versus ET, some of my patients feel a lot better, let's say when their hematocrit is less than 44 or 43. As opposed to 45, right? Even though the data is not there for it in terms of safety, it really helps their headaches, for example, or their vision, and they just feel better. So hematocrit's another thing I look at. And then, there's all these adjunctive treatments, kind of like on that slide you just presented, that can help itching that we use for other conditions like mastocytosis, for example, which is another blood cancer that causes a lot of skin symptoms. And I've tried those things, histamine blockers, leukotriene blockers. I think kind of like your other example, different things work for different people. And so, it's helpful sometimes to just circle through these treatments and see if one kind of sticks.
Great. All right. So I think we've touched on a majority of the questions. So I'm just going to ask anybody now, we're talking about symptoms. Does anybody have any specific questions that we can answer from a symptom perspective? We'll make this more interactive. Yes, sir.
Yeah, you mentioned with fatigue that there's some medication that
So I use this in my practice. I will say it's not always data driven, but we work, and I work with a wonderful palliative care team. And so we do a lot of partnership. We're at the Blood Cancer Center, and the team really sits with us in clinic and it aligns. So there are scenarios when people do have fatigue that is debilitating. And let's say you have an event, you need to get to work, you need to be, doing something for a certain period of time. There is a little bit of data, and we do use it clinically. Low-dose stimulants can be helpful in that scenario. I do that clinically. It's not for everybody. There's side effects with every medication, but that's certainly something that we have implemented in practice. Yeah, low-dose Ritalin, low-dose Adderall, those type things can be helpful. Again, not for everybody, but if there's certain things that people really need to get done, that can be an adjunctive. Other questions? Yes.
Yes, you mentioned you were the one supplement.
Yeah, that was the omega-3s. I will be honest, I've never used that personally, but that's the one p-value that was positive within this particular study. So no idea because I've never used it. But again, this is the problem with supplements too, is that there's really inconsistent data with some of that. So
One thing I have is
Mhm.
that listed in your
So it definitely can be, and we see that frequently. Then that tends to go along with the microvascular type symptoms. So again, that vascular change, those are the scenarios where I do think things like aspirin can be very helpful, and then really managing the disease itself as best you can. But tinnitus, again, that's a tough one, and it can be very irritating. Yes, ma'am.
Yeah, especially
the term bony chick realize.
bone pain is a tough one too. I mean, I try to avoid pain medications as much as possible, especially addictive ones. For bone pain and some of these other kind of more difficult to treat symptoms, that's a scenario where I might try something like a JAK inhibitor or a medication that can reduce some of the inflammation that's going on in the body. Even in scenarios where someone may not kind of meet the other requirements for starting treatment for other reasons. And your tinnitus just reminds me, I feel like the most common way that people can sometimes tell what their values are without getting a blood work is by their, usually for some reason, the symptoms up here, like headaches, blurry vision, tinnitus. Sometimes people will come up to me and say, I think my blood's gonna look bad today because I've been having these symptoms. So definitely correlated with blood counts in some way.
So the other thing that's been helpful is Claritin for bone pain. So that's another adjunctive that we've tried if people are having bone pain. There you go. Eddie, Claritin. Yep, we do use Claritin quite frequently. Yep. Other questions?
We're not too sure unless you are. We use it for other reasons too, for other medications that have kind of bone related side effects. No, it's a pretty safe medication. Yeah.
And I don't really know.
Yes. Yeah, especially during pollen season.
Especially during pollen season. Yes. Welcome to North Carolina. All right. Do you have more time? Should we keep going?
Yeah, you have
Plenty of time. Okay. Any other questions regarding symptoms, and then we'll move on to risk.
Very, very cold meal and tingling. Is that purple neuropathy or is it something else?
Another very common symptom, I think, with these conditions is neuropathy. Like you said, it can range from being painful to just being numb to being just that pins and needles type feeling. But you are definitely not alone in that sensation. Again, I think bringing it back to the main reasons why these things happen, it kind of falls more in the microvascular realm of just kind of poor blood flow. And so, not to sound like a broken record, but aspirin can be helpful there, and sometimes taking more aspirin than the standard one time a day can be helpful as well. But it's something that we see commonly in clinic.
The other thing that we've tried has been things like Lyrica and gabapentin. So some of the medications that are prescribed, say, for diabetic neuropathy, those can be very helpful, again, as additional adjunctive type therapies in that scenario.
Does that actually help your circulation, or if it's just peace?
That really treats the symptom. Again, what we would say is the way to really treat the problem is to treat the underlying disease, which, again, is obviously the big challenge with this. So any other symptom questions?
Memory loss.
Yeah. You guys are hitting all the high points. Yeah. So brain fog is, concentration issues.
Memory loss.
So it's a good question. I mean, I do think of them a little bit differently. But, cognitive issues in general are prevalent in people with MPNs. I equate brain fog more to trouble concentrating on your daily tasks, like reading the paper or watching TV or just, interacting with people and holding conversation. Memory loss, I think it's its own kind of can of worms. There's short-term memory loss, long-term memory loss, but all of it, I believe is more prevalent in people with ET or PV. Treatment-wise, I think that's a little bit tougher. I would kind of focus on the things that we have available to us, right? Like aspirin, like JAK inhibitors like interferons. Sometimes seeing a neurologist can be helpful. Getting some brain imaging can be helpful, but that's where it really starts, like, Lindsay said, to be more of a multidisciplinary kind of approach.
That's where I do think the team approach is really helpful. And you never want to have just one person. It's always good, I think, personally, to have more than one person, more than one set of eyes on things.
I have to laugh because they don't know one week FBC, MPN.
Oh, it always goes back to the MPN.
Yeah, all of this.
Yeah.
And then you go to your Danvers neurologist and they say, oh, no labor. Yeah, we're happy to pay.
Well, and everybody says, well, it's always the MPNs, which is true, right? Like the reality is there is something at the root of the problem. But I do think that getting at least input for adjunctives and treatment options is helpful.
I like the fact that they don't take responsibility. That it's, I don't know. That, I'm sorry, it hasn't been.
No.
And also, as you age, for you're older. Hey, you're supposed to.
I think it's helpful too to seek at least, if you guys are not doing this, a second opinion or care in more of an academic center like Duke or MUSC or wherever, we practice. I think within those places, there's a little bit easier collaboration between different specialists. We're all kind of working under the same roof. It might be a little bit harder to kind of foster that collaborative effort when you're dealing with different practices or different locations. But that's, I think that's something that we both try and focus on in care.
You also get, I think the challenge too, so I say this in clinic when patients come to clinic, I think that MPNs are the most common thing in America because that is all I see in clinic, right? So I am in clinic 2 days a week and I only see ET, PV, MF. That is it. I have not seen cardiovascular disease or anything else in a very long time, and I would certainly fail my boards at this point if I had to do it again, which is fine. But that's all I see. So there is some solace to that. I think when you come and you see somebody who only sees MPNs, that there's a very different perspective to it. We just see more of this rare disease, and I think we definitely just have a larger population of patients. So if you feel like you're not being heard, if you feel like you're not getting the information, then coming to see one of us or multiple of us, I've sent multiple people to Dr. Mesa. We've sent a lot that way. We've seen people coming from their site. And so I think that is truly helpful to get multiple people on board. And anybody who tells you that you shouldn't get a second opinion is totally wrong because you absolutely should, I think.
Just from an advocacy perspective, that all sounds wonderful, except more patients than fewer do analysis in them. And so there are some MPN physicians that will consult who was worthy about his name, and I did that on matter for the Lord, having a be in both in that that run altered identity situation was the other day, but we they should be work though, but if you can money on the lobby how whatever, but now he saw. So at the other growing part of the rating that they are way to do that because I would say the camera aren't doing the ability and have that luxury of going to an indirect DOE.
Yeah, BC, for sure. More questions?
Yeah, I had one thing.
Yeah.
My mother and my grandmother are
both have right. My son has DP and Dick has like the sprain call, but it was only one set. Actually,
You. So my question is there any more do they have high concern for him at the MPN? But he do get anything that I have to
I don't know of any established link between Alzheimer's and PV at this point. But the brain fog is real, and certainly there's a higher risk of, vascular things like mini strokes or strokes in the future that can cause memory issues down the line. So, I think it's important that he sees a great doctor like Lindsay, and gets good PV treatment. But I don't know if I would really. I wouldn't let the Alzheimer's connection weigh too heavily right now.
I think this also goes back to our last talk too, right? So we know that these diseases are inflammatory diseases, and there's something to chronic inflammation that just doesn't sit well with the body, right? And so I love that Dr. Elf is studying this, and I hope that we really nail down the exact mechanism of what's going on. But certainly there's definitely got to be a link with the chronic inflammatory piece to this. which again is tough because how do you manage chronic inflammation? Always the question. Did you have a question?
Yeah, I had a question related to like BCT.
Yeah.
In one of my episodes, it was
A very significant and noticeable step change in the fatigue that I manage.
and my rhythms hadn't changed that much, nothing else, no big stressors, nothing else. So it was, it's probably your thyroid. Right, yeah. No, but, and I mean, it was dramatic. Has there been any correlation that you can have these, like, exacerbation? I mean, it was significant.
But gee, it was like I heard you say something about, low dose stimulant. It was,
I don't even know if that would work. It was that extreme. And it's happened twice.
So I think there are so many aspects to PV and ET that we do not measure, right? So if you look at some of the trials that we're doing, we're looking at cytokine data, how that changes. Do cytokines go up? Do they go down? How does treatment impact them? And, inflammatory cytokines are a huge part to this, right? But we don't measure. There's no way to clinically measure that at this moment. So I would say we see this not infrequently. I've got patients who come to clinic and just say, look, I just have moments where I cannot go to work. I cannot get out of it. This is very common. I think what we need to do a better job of is figuring out why that's happening. Do are the cytokines going up? Which ones? What biomarkers can we use? And this is Dr. Pemeraji's, I think, big platform is, can we find a biomarker? How do we really, track that? And I don't think we have that yet. Hopefully coming soon.
It was like, trying to figure out what changed.
And maybe nothing. I mean, reality is oftentimes it's absolutely nothing. So, any other questions, or do you want to move on to risk? Should we move on to risk? All right, let's do risk. Okay, I'll turn it over. There you go.
Okay, so risk, again, trying to breeze through these slides, get to some discussion. There's a lot of risks with ET and PV. And, something that came up with our last talk, right, is that I think there's an audience comment, that CALR mutations are low risk or less aggressive, right, than JAK2. But I think it kind of depends on, what you're meaning by risk, right? And that's an important aspect of treating these conditions is that the thing to focus on for one person might not be the thing to focus on for another person. So someone might have great counts, low risk for, a blood clot, but they're so debilitated from their symptoms, they can't function, they can't go to work. Whereas someone else might have no symptoms, but let's say, has a history of a heart attack and is very, very, very concerned about another one. So there's a lot of different risks. Some are early, some are late. The things like progression to myelofibrosis or leukemia, which are more aggressive types of blood cancers, obviously happen later in the course of the disease, though can happen, earlier depending on when the diagnosis was made. There are some risk factors, right? Unless you're Benjamin Button, you're probably aging in one direction. And, as you get older, the risk of having a blood clot goes up. But it's not like, you celebrate your 59th birthday or 60th birthday and you have a great time with your family and you go to sleep that night and you wake up in the morning and you have to start hydroxyurea that morning, right? So obviously there's some nuance and there's some gray zone with age and how that correlates to risk. Heart disease, exercise, diet, obviously very important. Mutations in the bottom left, some are, more risky than others. I think we'll talk about that on the next slide. The blood counts. And then, history is the greatest predictor of anything, right? I mean, if you've had a blood clot before, if you've had bad symptoms before, that's a good sign that those things are the things to worry about for you. It's tough because I think our risk scoring that we use, if you talk about it with your doctor in clinic, is pretty archaic for the most part, right? I mean, we're basing it on a couple of factors versus other blood cancers. We incorporate 60 or 70 different variables depending on, mutations and blood counts. So I think a lot of this has a lot more nuance than that typical kind of, are you old or young and have you had a blood clot type stratification. Okay, some more questions. Let's do some questions, I guess, and then we'll turn to the audience. We'll do quick hitters here. So what do you look for when you stratify new people with ET or PV?
So let's see, ET. We'll do ET and PV together. How's that? I put them as separate. But okay, like we said, I think the conventional risk stratification systems are completely ageist, right? So again, it's not like you go to bed on your birthday and you wake up and you're now suddenly high risk. So I think that sometimes we get stuck in this thought process of high risk versus low risk based on age. And the reality is, I think about a whole bunch of different things, right? So I look at patients' cardiovascular risk, right? Do they have diabetes? Do they have a family history of cardiovascular disease? Have they already had cardiovascular disease? What are they doing from that perspective? We chat about things like, do you exercise? Or are you somebody who goes to the gym? I do not, but a lot of people do, which is great. I just run around after my kids. That tends to be more of an adventure. And then we're starting to think about things like mutations, right? So, I think we have historically used those more in the context of myelofibrosis, but now we're seeing more and more scoring systems looking at the role of different mutations, higher risk, lower risk mutations within the context of ET and PV. And so I personally, in my practice, you'll hear my soapbox if you come see me in clinic. I think that every single patient where we are concerned about an MPN should get a bone marrow biopsy. I may not be, people may oppose that, but I think it's important because you need to establish a baseline, you need to establish a diagnosis, and I think it's helpful from a prognosis, a diagnosis, and a long-term perspective for folks. So we will oftentimes at Duke at least send a myeloid next-gen sequencing panel, and this gives us various mutational information, and so we can use that in addition to cardiovascular risk. Patient's personal history, have they had a clot or not? Are they bleeding? Are we worried about acquired von Willebrand's disease in conjunction with some of these mutations to decide really if therapy is warranted? All right. And then why don't we open it up to the audience? How about any questions about risk?
Well, you measure a bone marrow biopsy. How prevalent you?
That's such a good question. That's a question.
I could say
No. So I do it once. I do it once at the beginning, and then I do it again if I am worried. So counts change or something different happened, then I will do another one. But I personally made
their bone marrow biopsy didn't mark the progression of the PD.
So I don't. I think clinically, at least in my practice, I don't know if you feel differently. I don't follow serial bone marrows because you can really tell peripherally based on blood counts if things are changing. We do have patients. There are people who come to clinic who will say, I need to know. And that's okay. I'm an information geek. I spent time in a lab. I love data. So there are some people who really do want to know, but I think clinically, if I'm not going to change management, if nothing is changing, I don't repeat things serially.
Yeah, I'm the same way. I agree about the baseline bone marrow, and I always tell people, if I was in your shoes and I was diagnosed with a blood cancer, I would want to know exactly what type of blood cancer it was. It's a clinic procedure. It's not a very high risk. And like you said, it's important, especially now with all the data we have about prefibrotic myelofibrosis or ET or all these kind of nuances. I think it's important. And then I agree wholeheartedly too. I tell people I'm going to repeat a bone marrow biopsy if your counts change. If there's new kind of abnormal white blood cells in the blood, if your symptoms or spleen get a lot bigger. I mean, there's definitely triggers for it. But the serial kind of every year, every 2 years, 3 years, I think it doesn't help us, at least in 2025. Maybe in the future we'll have some biomarkers to look at or something's a trend that can help us decide when to intervene. But I really get it as needed right now.
Yeah. Other questions, or do we have time to do treatment? Okay. Yep.
With information on their bone marrow biopsies, as I had a delay in treatment because he was on Eliquis, and the first hematologist had old information that she could not do the biopsy on Eliquis. So you have to hold for several days first, and that was a high risk thing. And it wasn't until 6 months later that we learned with the new protocol, that it's not the new. In fact, is that you can do a bone marrow biopsy on Eliquis, and we don't have to hold it. So there's a misconception out there that patients seek Medicaid for themselves.
So I think this is risk, right? So I think this is what we do in clinic all the time. So if you're on a blood thinner and get a bone marrow biopsy, is it a little bit riskier? Yeah, 100%. But I think if there's important information to be gained, then at least at our institution, we would obviously get it done. But yes, that's an excellent point. All right, do we have time? Okay, so let's run into treatment for ETPV. Maybe we'll go through a few slides and then we can again open it up for questions.
Yeah.
All right.
This one.
Yeah, I need this. Okay. So I made these slides when I first started seeing patients in clinic, and this was like in 2017. It was a while ago. It's not been recent. And I love that we're finally starting to see changes. So these are the current FDA approved agents for ET. So my favorite is dynamic monitoring, which I do a lot of. Because not everybody needs treatment. So number one, aspirin, which we talked about, cytoreduction, and then we've listed some agents there. So for ET in particular, hydroxyurea, anagrelide, and interferon. All right, so this is what we currently have, a lot more to come, which is exciting. All right, how about PV? So again, this is what's currently here, a lot more coming up the pipeline. So aspirin, we've talked about, phlebotomy, which I'm going to be controversial and say that I really don't use anymore. I try and avoid it if at all possible. I will use anything to avoid phlebotomy. Cytoreductive therapies, including hydroxyurea and interferon products, which are my personal favorites. And I think Dr. Pamaraju has heard me say this before. And then ruxolitinib in the second line setting for patients with PV. But again, I think the pertinent point I take away from this is I made these slides 7, 8, maybe 10 years ago. I'm going to age myself here. Although not quite like the View did, I will say. How's that? And there hasn't been a lot of change. But I think the exciting part to the field right now is that we are starting to see changes. Okay. So I'll give this to you. So these are questions that you should be thinking about. And then we'll go to questions for us.
Yeah. I mean, these are some of the ones I think are important. I mean, I think most people here might be more kind of into their journey with ET or PV or your MPN, but like we were saying, I think the goals of treatment are different depending on your situation, right? Your symptoms, if you have other medical conditions, et cetera. So, I think it's important to kind of establish with your physician, what are the goals of treating me right now, right? Are we trying to prevent blood clots? Are we trying to improve my quality of life? Are we trying to prevent myelofibrosis from developing? And that's going to inform how you kind of come to the right treatment for you. Every treatment, even monitoring to some degree, has some pros and cons, right? So, make sure you're aware of those before you set off on your journey. Always ask about clinical trial options. Like was just presented, we've had very little updates in the last 10 years. I think we have a ton more clinical trials active right now at, all of our sites than we did a decade ago. So it's always important to kind of consider those. Yeah.
All right. So we'll start with a couple questions that we'll answer, and then we'll open it up and we'll just go from there. Okay. I like the top line.
Yeah. I was going to give a shout out to Dr. Seuss here. I became a father this year, and so I've read the same book like 50 times, and one of them is The Places You'll Go. And whenever I come across this line, it really sticks with me, right? Because I mean, as physicians, I feel like one of our main jobs is to just kind of give people possible options and work through with them. And it's hard a lot of times. It's hard to find the right treatment for any one person. So I'll ask you the first question: when do we start treatments? Who needs treatment and who doesn't? That's a huge question right there. That's a loaded question. Yeah. That's a tough one.
All right. Well,
let's go to the audience, right?
All right. You want to go to the audience?
Yeah. That's
all right. Well, let's go to the audience,
yeah.
And we can always come back.
Yeah.
How's that? Should we open it up for treatment questions?
I'm another light Bible waiter parent.
Yeah, can you expand on what some of the clinical trial things that where you see promising?
Yeah. So I mean, there's.
You want to do PV and I'll do ET?
Oh, sure. I was going to do ET, and it's okay.
Yeah, it's okay.
So either one, but ET. There's I think probably the most exciting thing is, like Dr. Elf was talking about, CalR directed therapies. That's only for about maybe a third of people with ET, and so there have to be some other kind of developments as well. There was a large trial that was just kind of presented at the European conference called Surpass ET that looked at interferon versus anagrelide in people who didn't do well with hydroxyurea, and that seemed to be in favor of interferon there. So kind of looking at the next best step after maybe hydrea is not working anymore. And then there's other kind of other pills and there's a drug called bomedemstat, which is it's an LSD1 inhibitor. It's not that LSD. It's a different enzyme in the body that's looking very promising as well. And that's currently in phase 3 trials, meaning that we're trying to see if it's better than the standard of care for people who haven't done well with hydrea. And there's another trial with it looking at it in the first line. So we've got studies for CalR, we've got studies for non-CalR ET, and that's not even to mention things like cellular therapies, like transplants or CAR T cells, a bunch of interesting things.
And I'm going to be provocative this morning and say that I don't think there's a role for hydrea anymore. I think the role for hydrea is very rapidly waning. And I think this is probably true in ET and PV. And so when folks come to my clinic, we sit down and we talk about something that I've learned from the MPN community over the years is really to think about modifying the disease, right? And so I think when you're thinking about treatment in ET and PV, what we say to patients is, look, we know that phlebotomy for PV is going to do absolutely nothing in terms of modifying the disease. It's just going to make you iron deficient. You're probably going to feel worse. Okay. I can tell you that hydrea is not going to modify your disease. We know that. It's going to suppress your blood counts, and that's all it's going to do. So in my mind, and I think the way that I think of this is there are therapies out there where we may get disease modification. So we know that there's data for interferon products. I'm a huge advocate of interferon in various forms. And there's evidence to suggest that some of these trial medications like the LSD1 inhibitors have the potential to modify disease. So as we approach patients with ET or PV, I think that's something that always comes to the forefront of my mind. So let's talk a little bit about PV. I think of utmost excitement is the fact that PV this year made the plenary session at ASCO. So this is the first time in decades that a therapeutic agent for polycythemia vera made a plenary session. And certainly at ASCO, which tends to be a meeting that is really focused on solid tumors, right? So I happened to be at a meeting in Florida with one of the with some of the folks who were working with ASCO. And it really has been decades since heme malignancies have made the podium like that. And so there's multiple agents that are coming. So there's for PV, again, when we talk about trials, we've got things like rusfertide. So these are hepcidin mimetics, agents that alter iron metabolism, because in PV, we know that patients have altered iron metabolism and altered levels of hepcidin and various other regulators. And so I think the focus and one of the large focuses in terms of what trials are available right now are really on targeting that pathway. So again, rusfertide, a hepcidin mimetic. You've got other agents focused on different aspects of that particular pathway, and there's trials that are going on right now. Some of those agents are nice because they're injectables, and so they're not something that you need to remember to take every day. For chronic medications, that can be problematic. And then, like we mentioned before, we've got things like the LSD1 inhibitors, which are also being trialed within the context of PV. And so multiple options, multiple trials, some are complete, some are in progress, but lots of stuff coming up the pipeline.
I want to be really controversial. I'd ask you.
Oh, controversial. Yes, those do.
We can talk about this offline, but is rusfertide the new phlebotomy? How will that fit in? Well, I think there's a whole session on future therapies too.
We'll go for questions from the audience. Any questions we can answer from the get-go? Therapy for ETPV. Yes, ma'am.
Why think you didn't mention this combination?
Oh, I love it.
Yeah, it's a great question. There's I'm interested to hear what your practice is. There's been some studies, fairly small scale, like 20 to 50 people enrolled, that have looked at some combinations like interferon and ruxolitinib, for example. In my clinical practice, I haven't used combinations a whole lot. I found that typically with interferons or ruxolitinib, I can get a decent handle on people's blood counts and their symptoms. But I will say I have, off label, used combinations in a few people, and I've had decent results with them. I think it might be a little too early for kind of prime time is my takeaway.
I think this is where the personalization part comes in, right? So I think it's different when you're thinking about a 29, 30-year-old coming in with a new diagnosis as opposed to somebody who's, let's say, 80 or 90. And so I think you really have to think about the patient. I love that we're starting to look at combinations, but again, I think there's a lot of things to think about. So cost is really going to be a factor, right? These agents, a lot of them are not inexpensive. And when you're taking two, how does that impact patients' quality of life, cost of living, the whole 9 yards? And then you're going to have to worry about overlapping side effects, right? So everything comes with a side effect in general. And so can you get control with just one, or do you need to take on additional side effects for that added benefit? And again, I think that's where oftentimes you look at the patient and kind of think about the whole picture. I personally do not use combinations at this time, but I think as we see more data, as these trials are reading out, as we're getting more information, I think that's going to be an ongoing discussion and something we start to think about. Certainly. He had a question.
So, rusfertide and LSD then modifying?
Ooh. Okay, so I think we don't know because these are so new. So I'm going to say that I'm hopeful, but I think we don't really have definitive data yet. I don't think we've had enough of a readout to really to come to that conclusion. I think we have a lot of data, and you can probably tell some of my bias as I'm standing up here talking about this, and he's probably going to laugh at me at the back of the room. I think we have a lot of data looking at interferons, right? And we know that those do modify disease. And so I think there's decades worth of data there. But again, some of these newer agents, they're newer agents. We just don't have that information yet.
How for the interferon parallels number of patients that have that without an spec?
So it's real, right? And I think, so again, this is what I tell people in clinic. So I had an old mentor who's actually in Charlotte now by the name of Dr. Dave Rosieri, who every time I would say, I want to use interferon, looked at me like I had three heads. Said, you're nuts. This is not going to go well. Nobody's going to tolerate it. And the reality is, I think if you come to somebody who does it all the time, who uses it all the time, you're going to get a much better experience, right? So I am probably Duke's largest user of interferon-based products. I use a lot of it, right? So we check immune labs at the get-go. We monitor them. We've got the protocol down pat. And so we do see people develop autoimmune issues. We do monitor for that. And I think, again, that's the benefit of seeing somebody who only sees MPNs or sees them more frequently. There's just more experience to know what to look for and how to mitigate some of those side effects of the different agents. Yes, ma'am.
For someone who shows features of both ET and PD, I had bone marrow biopsy. One pathologist said ET. It was ret uretridine, and they said it's actually pure PV. My specialist said you have features of both. What does that mean for risk, and what does that mean for treatment? Risk both in your overall kind of profile, but also for progression to MS. And is there any science on that? And also, does having features of both argue more for an interferon-based therapy versus a?
That's a great question. I mean, that's a question I probably ask myself the most in clinic because, we try and put things into little boxes, right? We try and check off these things to say someone has ET or PV, but, obviously the real world is much more complicated than that. And, there's some thoughts that these are very distinct diseases, and then there's some thoughts that they exist on a spectrum. I think in reality, probably no one knows 100%. But there are features that they can share, and that can make it really difficult, right? And a lot of people who I see don't just have a high platelet count, right? They have a high platelet count and a high red blood cell count, and maybe their JAK2 is at a certain level that's in between what we'd expect for both. So I think the best answer is, I personally, I struggle with those situations as well. I think in terms of risk, we know that, maybe some features of PV are a little bit higher risk for things like having a blood clot or like progressing to myelofibrosis. And so, I think where the numbers fall on any kind of timeline can help risk stratify. For the interferon question, I don't know, if it matters too much, honestly. I think, if you have an MPN and our goal is to prevent that from getting worse, maybe it's a slightly higher chance at baseline with PV than ET, but, interferon is the drug that has the most evidence to help prevent that. So I think the distinction is almost like a little bit more academic, I think, in some ways. I think, especially if we're moving towards more disease-modifying therapy, the treatment might kind of be similar no matter what the specifics are.